Hello, I'm Jung Yu-seok, and I will be giving a lecture on the topic, How Far You Can Go Digital. I graduated from Chosun University School of Dentistry and trained in prosthetics at Korea University Annam Hospital. I currently give lectures as a key doctor at Implant. Before lectures, I always prepare my mindset first. First, I want the lecture to save time for my audience. And rather than conveying the theory, I will be giving a lecture that conveys the experience. Also, the motivation is important. I hope this lecture can give you the motivation of digital. Next, I will discuss things many people are curious about, such as how far it is appropriate to introduce the digital method to your current practice and what to do to minimize redundant investment. I will give the lecture on the key points that are needed in digital clinical phase for accurate surgery and overall fit. I started using the digital method since 2014. When Trios 3 came to Korea in 2014, I purchased and introduced Trios 3. This is when I started using the DIOnavi system. So I used navigation implants since then. It was when everyone said oral scanning can't work. I heard from many that oral scanners don't work well. I purchased the oral scanner at Trios 3 at the time and began navigation implant with DIOnavi. I've continued to use it since then, and now I use the digital method for not just singles, but for aesthetic prostheses, full jaw prostheses, and dentures. Let's take a quick look at the kind of treatments that I have converted to digital method in my clinic. First of all, we use the digital method for the basic single crowns. Next, we use it for one-day treatments such as one-day inlays and one-day crowns. We help patients receive treatments and leave the clinic on the same day wearing new teeth. We also started one-day zirconia. It takes 5 minutes for the milling and only 20 minutes for the sintering, so we created a system where patients can put it on and leave on the same day also. So the premolar here is a one-day zirconia. We proceed in this way and pre-design the full mouth implant to proceed with surgery and prosthetics. I use DIOnavi for flapless surgeries. That's why it can look this clean after implant replacement, and it only takes an average 10 minutes. Next, this is a digital modeless method. It's a full arch prosthesis using only digital. At this time, the prosthesis is done digitally by scanning without making a physical impression. Many people say that digital method won't work. It doesn't fit well. Digital is too difficult. But I perform simple single crowns to full arch prosthesis using the digital method. So I want to share about that today and show that these things are possible. When we talk about digital dentistry, normally there is the navigation implant, which is a guided surgery, and a modeless prosthesis. I'll talk about these two things. First, when we say that we use a surgical guide, normally it is seen as something used by beginners. And second, people say they tried using the guide, but it wasn't very accurate and didn't fit well. These are the common comments. So I want to go over each of those points. This patient was referred from Asan Hospital shortly after I introduced the digital method. As you can see in the picture, the wear was very severe and the occlusion was very poor. This was a 74-year-old male patient. He came into the clinic in this condition. The wear is very severe and the teeth were raised a lot. This patient, as you can see by looking at the tongue, had tongue cancer previously. So the patient thought that he had got tongue cancer because the dentist made the prosthesis too sharp. That's what he thought. So he was very distrusting of dentists and was a very picky patient. So when patients like this come in, the treatment is not easy. This was when I had just started using DIOnavi. I thought that using DIOnavi to approach this patient can make things easier. So I approached this case with DIOnavi. What's good about navigation implant using DIOnavi is that you design the crown first and proceed within a top-down method. So the prosthesis procedure is always very clean. Especially in this patient's case, because the occlusion was very poor, if I go into the operating room and adjust the angle and the depth of the implant, it will be placed in a position I didn't want and the operation time can increase. But since the plan was made ahead of time and it was placed at an accurate location, a very clean result was achieved. So this is the surgery using DIOnavi. So I placed 5 implants now, then a temporary implant, and proceed with extraction. All this process took only about 50 minutes through DIOnavi. What I thought at the time is that for a case this big and difficult, I wouldn't have been able to finish this quickly and this well if I didn't use a guide. So I connected the temporary tooth to the temporary implant so the patient could eat foods. Then, for the top part, air pockets were raised on both sides to place 2 implants. I used DIOnavi to place the implants as well. It took only about 30 minutes total to raise the maxillary sinus and place the implants. This is the panoramic image of the patient after the surgery. Since the VD was raised high, it took about 2 months for the adaptation period. After making temporary teeth by mounting it on the articulator, the patient went through an adaptation period using it. After the adaptation period, the final prosthesis is completed like this. Even though the patient was very picky and had mistrust in dentists and therefore didn't cooperate well, I was able to finish the case smoothly by using DIOnavi digital guide. The patient comes diligently to his regular checkups even now in 2022. He was so satisfied that he introduced his wife to our clinic, and they both received treatments from us. People think it's used by beginners, but you can think of DIOnavi as a tool that shines brighter when the case is difficult, like this case. People who have used it in the past say it's inaccurate. It did have those problems, but let's see how those problems have been resolved. Yes, the guide in the past shook a lot like this. Therefore, there were a lot of errors even when trying to place it accurately. But DIOnavi guide reduced the tolerance greatly, so the accuracy has improved a lot. Due to these parts, even more accurate surgery is possible. Then, there may be opinions on how accurate it should be when using a guide. In general, the safe distance between teeth and the safe distance between implant and teeth and between implants are said to be around 1.5 to 3 millimeters. When we look at this, if you try to place a 10 millimeter implant and there is a 1 degree rotation from the top, then it causes an error of 0.34 millimeters on the bottom. So if it's this thin and there is a 1.5 millimeter space between the adjacent teeth, the error has to be very small, like 4 degrees or 3 degrees, so that it doesn't touch the adjacent teeth. And even if the outer bone is as thin as 1 millimeter, the error must be within 3 degrees, so that this will not cause any problems for the patient and the guide surgery will be performed. So, for the guide surgery to be successful overall, it should have an error within 3 degrees. DIOnavi can have this accuracy because it uses a long tube like this, which reduces the drill shaking greatly. So, compared to other guide systems, the operation can be performed with less error and more accuracy. So this was a case where the surgery was done accurately using DIOnavi. This patient was a 49-year-old female patient. She was scared of the procedure and wanted to proceed with implant placement without cutting the gum and bone grafting as much as possible. Since the tooth was very thin, I informed the patient that if there isn't enough bone on the outside after placing the implant, I might need to cut the gum and proceed with bone grafting. This is what it looked like after placing the implant. I used DIOnavi implant to place it accurately like that. If I didn't use a guide, I don't think I could have placed the implant with that much accuracy. The top left image is before the surgery. On the day of the surgery, we placed a temporary tooth. Next is what it looks like with the prosthesis. And she continued to visit our clinic after, and this is what it looks like 3 years after the surgery, 5 years after the surgery, and 6 years after. She continues to maintain it well now. Since the bone was thin, around 1 millimeter, there was concern that the outer bone of the gum might melt. If you can place a flapless implant, leaving about 1 millimeter exactly, you can see more stability even after placing the implant in the thin area. Next, other than errors from the guide, people say that there is error caused by using DIOnavi. Some may say that there are problems with using DIOnavi. Let's take a look. Errors occurred frequently in cases like this. So if the teeth are all present in the front, but the teeth are missing in the back like this, I examine errors when DIOnavi was used. When we design the surgery, we go through an adjustment process. We use the oral scan and CT together to diagnose. If misalignment occurs in this process, it can cause errors. This is what the adjustment looks like in Implant Studio. If we adjust by creating 1, 2, 3 points like this in the front, it will show up as green, as you can see on the top left, which indicates that it is correctly aligned. So we can consider that it is well aligned, but it sometimes deviates during the actual surgery. To simply understand why this happens, think of when we put a screen projector on our phones. We align one side first and move to the other side, but as we move, it doesn't align well. It's the same with implants. We align the front part, but as we go to the back, it moves and causes error. So the solution here is to line both sides, like you would with a screen projector, and then start from the middle. For implant guide surgery, instead of aligning the front only, create something in the back you can align to as well. Then you can align both sides, and the surgical part in the middle will fit accurately and eliminate errors. So the method that was created was placing resin markers. By using the 5th generation bonding agent that is frequently used in the mouth, put on the bonding agent and cure lightly. Then, use a flow resin and cure again. Then it will become like teeth and not move. By using the front tooth and the resin marker in the back, the misalignment in the adjustment process will reduce greatly. This can be seen as a key point in performing accurate surgery. If the guide and other things are made well and the adjustment proceeds well in the surgery process, then errors can occur from another place. Misalignment can happen during the surgery. Like the picture on the left, the drill can be pushed away if the bone sticks out like this. For this part, in the analog surgical method, we would open the gum and use a round burr to smoothen and flatten the area and then proceed with the surgery. For guide surgery as well, there is a bone flattening drill that flattens the top part. It should be used sufficiently to prevent the drill from slipping. This is an important key point for accurate surgery. Next, the third point for accurate surgery is the use of a tube. Using the drill tube reduces the tolerance a little more. And when you use a short tube, like you see in image A, it can become misaligned. But if you use a long tube, the misalignment is much less. So, if you use a drill tube like this, especially if it is a very difficult case, you can see that the procedure will be more accurate if you use a long drill tube. Next, the fourth one. When we place an implant, we use a final drill. When we use the final drill, there is a sleeve made of metal on the guide. When we use the drill by contacting the sleeve part, then it follows the guide well without moving around. So the implant must be placed by maintaining sleeve contact. Guide surgery is an accurate surgery method, but if sleeve contact is not made, then it can go off in the wrong path while it's in the air. Then it will continue to be misaligned, as you can see in the picture. So when you drill, you need to have contact on the metal sleeve. You need to check this before drilling. And if the drill is floating in the air, then you need to use a shorter drill to maintain sleeve contact. If you proceed with the surgery this way, it will be much more accurate surgery. You can consider this. So far, I talked overall about performing accurate guide surgery. Second is prosthesis. Many people ask about the possibility of digital prosthesis. I will go over each point in a practical way. People normally say it doesn't fit well. I've been doing prosthetics myself for about 3 years now in the clinical practice. I perform the surgery myself, and I make the scan and design the prosthesis in Implant Studio or a dental system and fit it in myself. I've done this for 3 years. So I can confidently tell you that it is possible. Let's take a look at a case. I've shared this case before. For this patient, the implant was placed and the prosthesis was done modeless without making an impression. Usually for full mouth cases, it's hard for it to fit well even when an impression is made, and it takes many adjustments. When proceeding digitally in a modeless method, the possibility of errors can be eliminated one by one, and a very convenient and accurate modeless prosthesis procedure can be done. This is the next case. You can make guides not only for general prosthetics, but also for periodontal surgery and crown lengthening. So I use the digital method to make guides like these. In this patient's case, the length of the teeth is very asymmetrical, so I proceeded with the prosthesis by cutting the gums. I used a facial scan and then the CCL guide like this to proceed with the prosthesis. If you can't see the face when performing anterior prosthesis, there may be some aesthetic problems. In this patient's case, a beautiful prosthesis was made by using a facial scanner. Next, for the parts that are said to not fit well, let's look at which parts make it not fit well and how to make accurately fitting digital prosthesis. First, the reason why it doesn't fit well is important. The first thing that could happen is error that could occur while acquiring the bite. In the past, when I scanned with the Trio scanner, I didn't understand the gap between the teeth. When we make a model with a plaster, it doesn't form a gap because the two are put together. But when we scan using an oral scanner, there is a part where the two strangely overlaps. In the past, it was thought of as an error and that the whole area was redone. That's why the prosthesis made through oral scanning didn't fit well and was too high in the past. Now, the fact that a gap forms is because the teeth usually goes in the periodontal ligament. So once you understand that this is due to that, then it eliminates a lot of the errors. Second, we need to minimize the errors that occur while obtaining the oral scan. As there can be errors when we make an impression with rubber, it is important to understand the errors that form from oral scans and ways to reduce those errors. When you scan, there is this thing called framework scan. It's important to scan in one continuous movement. I'll explain this part again later. Thirdly, it is very important to make sure to use an articulating paper before scanning the mouth and compare it with the bite. I'll explain that too. Next, it is very important to have the design for prep and prosthesis design that considers the properties of the milling equipment so that it can be cut by the milling equipment. So, if we keep to all of this, we can proceed with the modeless method. In fact, I designed the prosthesis with CAD for 3 years and managed these things myself. So the important things are the milling equipment that can minimize such errors and the overall management such as the calibration. First, the scan needs to be accurate. To put it simply, a scan can be thought of as putting together photos like this. Like a video, it captures the whole area and slowly connects the images. Like when we take a panorama photo with our phones, it gets misaligned if we take it too quickly. So we need to scan slowly. So these parts are important. You can get a more accurate scan by holding the reference point after fixing the position for about 1, 2, 3 seconds at the very first position and scanning slowly. You can think that all scans are the same, but based on the person's scanning and the device, there may be differences in the scanning error. So we should pay attention to those parts. Also, when we take a scan, the bite could strangely come out on the left side and then the right side. This could happen. This happens not because a patient actually bites on the left side more and then changes to the right side. It's because there is an error with the scan itself. So error can occur based on the bite location. That's why it's important to know how to take accurate scans. For this photo, when the scan is done correctly, you can see that the bite is similarly bitten no matter where the bite is taken. So, in this way, it is very important how to accurately scan the entire mouth. This is a scan method from Trios. The important point is to take one continuous scan without any interruptions in the middle. Let's take a look together. This is shown often as a demo. It's a one continuous scan. Instead of stopping in the middle, it's taken continuously. The inside and the outside are both taken continuously. Even when some parts are not clearly scanned, the shortcut to a more accurate scan is to not stop, but take one long shot and then supplementing the necessary parts after. In that way, once you take the overall scan in one continuous scan, next, scan the parts that are important, the area that you are trying to create. Then, there will be less scanning error. Always take the scan of important parts first. You can take an overall scan like that, and then take the bite. As you saw earlier, one continuous scan, and if necessary, proceed by checking which area is lacking and add on. Second, the occlusion needs to be accurate for the prosthesis to be accurate and not high. One method you can use for this is to use an articulating paper. For us, before we take the scan, we use an articulating paper to obtain the occlusion in the mouth. Then we compare it with the actual oral scan. Like this, we checked the red dots on the articulating paper and then proceeded with the upper oral scan. When we took the bite after, these points were pierced like this. So if the points on the articulating paper is clearly pierced like this, then you can know that the scan is accurate. So usually after we take an oral scan, we don't check these things and send them straight to the laboratory. But even in the laboratory, it is hard to make it match if an accurate scan does not come in, no matter how much work you do. So these things must be checked by the dentist after the scan. If you check for bites on both sides and check if the pierced area on the oral scan and the bite points match, then you can minimize the adjustment time it takes inside the mouth later. Third, we need to prepare in consideration of everything to fit the milling burr. For existing teeth, it doesn't matter if it is gold, but when we proceed with milling, these sharp areas cannot be shaved because a round milling burr is used. So in consideration this, the prep itself needs to be more round. It's the same for inlays. For some inlays, if there are these very sharp areas, the milling burr cannot go in, so it won't fit and can cause a problem. So you can make it smoother in the prep. In the same way, this happens frequently in the anterior section. If the cut is thin and milling is done in that area, since it can't be milled sharply, it becomes over-milled and takes up a lot of space like this. Then, problems can arise in this area later. So in the prep, it is important for the prep to be rounded so that the cut can be made more widely. Also, for the margin itself, if the margin sticks out like this, then the prosthesis can't fit. So it's good to make this part fit smoothly. Next, if the inside is also sharp, fractures can occur due to stress, so these areas are also smoothed out. For the margin, deep chamfer margin is the most suitable margin when considering the milling burr, so you can obtain a much better fitting prosthesis if you complete it using the deep chamfer margin instead of box or shoulder. For the undercut, be careful of sharp areas and J-shaped margins and smooth out the sharp areas. Next, custom abutment and zirconia prosthesis can be made to fit in one try by using split design. This as well, if you make the design in consideration of the milling burr, then you can easily achieve the fit at once. So pay attention to parts like A, where it comes in contact with the prosthesis. You can make this round part more round. Also, for overall taper incline, it's good to set it to about 4 to 6 degrees. For the neck area of the implant custom abutment, if the custom abutment is shaped to create a rounded angle with over 0.75 or 0.8 to 0.9, which is more than half of an average burr diameter of 1.5 millimeter, then you can make the zirconia custom abutment at once. So, if you keep these things well, then it is possible to create modeless prosthesis at once. So modeless is possible. I've been designing everything myself at the clinic in the modeless method since 2018. People say that it doesn't fit well, but it's been very accurate for me. So from simple single crowns to full mouth procedures, I proceed with the modeless method. If you control all the potential errors from the scan, design to milling, then you can create prosthesis that doesn't need much handling. Also, our clinic uses a custom milling equipment. So the clinic takes care of the milling and finishes everything as a one-step clinic. Since I am describing what I've seen myself, you can be sure that it is possible. So there are various equipment at our clinic. Since these equipment are very expensive, if you want to introduce the digital method, it's very important to avoid repeated investment as much as possible and to set up the equipment well. So I imagine how I would set things up if I were to open a new clinic again. First, if you look for the cheap option, you end up buying the better version eventually. So I think it's better to bring in the important ones that are really needed in stages instead of buying cheap ones. So if you are opening up a clinic again using digital methods for the first time, I recommend you to buy equipments one at a time according to your situation. It's not good to overdo it. So if I am to open a dental clinic again, then I would first use a scanner to use guides to perform navigation implants such as DIOnavi. And next, once I see enough demands for the guided surgeries, then, to save the cost on guides, I would consider printing at the clinic using a 3D printer. And then, if I still see much larger demand for implant cases, then I would bring in a milling equipment. I always say this, but the digital method that the patients like and the digital method that the surgeons like are different. It helps with the clinic's management when the digital method that the patients like is used. And it's a way to prevent excessive investment by the dentists, so it's something to consider. To be honest, the 5-axis equipment is very good for the surgeons, but from the patient's point of view, incision-free guides and one-day implant prosthetics are much preferred. So it's good to think about these things when you make purchases. So for our clinic, all impressions utilize oral scanning. Impression material is only used for dentures. All surgeries are 100% guide surgeries, and it's manufactured in the clinic using Implant Studio. For inlays and onlays, we proceed with CEREC one day. For prosthesis, most are manufactured in the clinic in the modeless method. Custom abutments are also made in-house with round bars, and we don't use gold now. There is a difference after incorporating digital method. Our neighborhood has over 24 dental clinics, so it could be a difficult situation in terms of management. On the contrary, digital navigation implants and one-day prosthetics became our differentiating point, and we've seen an increase in revenue even during the COVID-19 pandemic. Many say that the digital method cannot work. In fact, that's what I thought when I heard this a lot. This case from 2017 is a combination of the digital method and all-on-4. Many say that it won't work even for a single crown, but this has been possible since 2017. So those people who lack gum get the all-on-4 procedure. It's the method of placing 4 implants and fixing it. It's a surgical method started by Paulo Malo that's been used widely around the world for decades since 1988. You think of it as recovering the dentition by placing 4 implants on one side. This was a male patient in his 40s. He felt a lot of discomfort with his dentures, so he placed 4 implants and began the all-on-4 treatment. I placed 4 implants without incision using DIOnavi. The existing procedure requires a large incision like the right side, but with DIOnavi, you can comfortably place the implant with minimum incision. So I placed the temporary prosthesis we prepared ahead of time, and after we waited 1 to 2 months for the osseointegration period, we completed the procedure with the final full zirconia prosthesis. This is the completed look. Many said that the digital method won't work, but even from 2017, full digital procedures in the modeless mode was possible. It's even more accurate now, so there's even higher potential. This is a 6-year follow-up photo of the previous patient. Even after 6 years, the prosthesis is kept well and clean overall. On the contrary, the bottom part that used dentures has broken teeth and appears to be in poor condition. This is an all-on-4 modeless case that used facial scanning. For this case, I designed and made everything from the implant to the prosthesis. I placed the implant in the modeless method like that, and the milling was done in-house by me. For the gingiva, it was colored myself using Mio, and it was manufactured in-house. This is a passive fit to see if it fits precisely. If it doesn't fit precisely with the full zirconia, then it breaks during the tightening process. So if you eliminate those potential areas one by one, then you will be able to fit the full prosthesis at one try like that. This is the overall look after tightening. Next is to check the occlusal adjustment. You can see that the occlusion is very good on both sides, even though this is before occlusal adjustment. The digital method is not in the early phase, so anyone can easily use it now. Using this method, our clinic performs DIOnavi full arch procedures. We do a lot of full arches. Even patients who come in with a bad condition, like this patient smiling, they can have beautiful prosthesis like this. Usually, if the bone in the gum is poor, the teeth lengthens and the prosthesis doesn't look pretty. But full arch prosthesis starts from the gum, so we are able to make beautiful prosthesis like this. All the other patients as well received full arch treatment and have recovered their teeth. Like this, it's not the problem of if a single crown fits or if a bridge fits, but even full arch prosthesis can fit well using the digital method. So you don't have to be too concerned. The digital method is not in its early days. It's actually the time to implement it now. My goal was to make all of these things in-house. So we proceed with all of these things right now.
그다음 지금은
Next,
이거를
going beyond this,
벗어나서
we use digital dentures to make dentures.
디지털 덴처를 이용을 해서
We even proceed
플립까지도
dentures with
보철로,
digital
디지털
prosthesis.
보철로 진행을 하고 있습니다.
We use the
그래서
PM7
이보클라에서
machine
나오는
from
PM7이라는
Evoclar to make
장비를
digital
이용해서
dentures.
디지털 덴처를 진행을 하고 있고요. 네.
If you look here, milling happens like this using the milling equipment. Previously, the gum and the teeth were milled separately and then put together, but now there's a block called Evoshin from Evoclar. So in this way, it shaves the top and bottom teeth at once, so the teeth won't fall out and even teeth in a very small space can be shaved nicely. So when we use milling, the time it takes to make one denture is about 1 hour and 30 minutes. So in this way, digital dentures are made using equipment like this. Previously, before these equipment were used, the patients had to come to the clinic about 5 times for the denture. But with the equipment, it can be done in 2 or 3 visits. If there is an existing denture, then it can be completed in the next visit. Normally, you see that there is a weak retention in dentures due to polymerization shrinkage. But milling dentures do not have polymerization shrinkage, so these areas are much more precise. So even without a special surgical method, it has very good retention. For this patient as well, we made a digital denture for the maxilla and it had very good retention. So you can see that these treatments are all possible. Yes, the top left here is a different female patient. We also made a digital denture for her, and it had very good retention too. We looked at the digital method overall. This is a copy from a Harley-Davidson advertisement. It talks about someday. You say I'll do it someday, but there is no day called someday. This is a quote from The Matrix, said by Morpheus. There is a difference between knowing the path and walking the path. I share this image because it's something you can consider as you think about staying in the analog method or going into the digital method. I hope this lecture was helpful to you guys. Thank you.